Our next speaker is Dr. Alex de Figueiredo. He's here virtually. He received his undergraduate and PhD degrees from Imperial College London and a Master in Science from the University of Oxford. He earned master's degrees in both theoretical physics and mathematical modeling and scientific computing, while his PhD is in applied mathematics. Dr. de Figueiredo is currently a research fellow in the Department of Infectious Disease Epidemiology at the London School of Hygiene and Tropical Medicine. And he's also statistics lead at the Vaccine Confidence Project. The Vaccine Confidence Project has worked for over a decade to map confidence on a global level in order to inform the strategies and designs for immunization programs so that human and financial resources can be designed for and with the communities they serve. Dr. de Figueiredo's global, national, and local primary research interests lie in estimating, forecasting, and mapping global, national, and local trends in vaccine confidence and coverage, as well as understanding the link between vaccine behaviors, socio-demographic group, and vaccine policies. We're excited that he will share his work with us. Welcome to the Hilltop, Dr. de Figueiredo.
Thanks very much, and thanks for the introduction. So good morning, everyone. It's a pleasure to be here today. Thank you very much to St Edward's University and Trish for organising today and inviting me to present to you on the topic of vaccine confidence. I was going to give a brief bio, but I think Trish has absolutely smashed it there for me. So just to say that, yeah, my background is quite quantitative. I enjoy the application of stats and mathematical modelling to public health and problems in public health. Conscious of my background in maths and statistics, I won't go into too much technical detail today, or at least minimal detail. And when I do, I'll point you towards some references and books in case that particular element of the talk interests you and you want to read further. So today so this is the talk outline. So I'll start off today by talking about vaccines, why vaccines are important, and why it's important to monitor confidence in vaccines. I'll then give you a bit of an introduction to the Vaccine Confidence Project and what we do at the Vaccine Confidence Project. And I've put our website here, so please feel free to visit us at vaccineconfidence.org. Although I will note that the website is undergoing a pretty major revamp at the moment. So while I do encourage you to visit now, if you were to come back in a month or two, what you'll find is that there will be lots of new data visualization tools, including a lot of the data that I present today. So if that interests you, do come to the website now, but check back in a month or two and you can play around with all of the data. So then I'll get into the talk, and what I really want to talk today about is 3 studies that we've done over the past 3 years that I think are interesting and hope you find interesting too. So the first study is about mapping global trends in vaccine confidence. So what does vaccine confidence look like around the world? Where is confidence high? Where is confidence low? Where was it high and where is it becoming low? The second study that I'd like to talk about is more COVID relevant. So before the COVID-19 vaccine was actually rolled out into the United Kingdom, which was in December 2020, we did a large-scale survey of individuals across the UK, and the aim of that study was to try to predict what vaccine uptake would be subnationally in the UK. So in fact, we surveyed about 17,000 people across the UK and tried to estimate vaccine coverage, future uptake of the COVID-19 vaccine across 174 subnational regions of the UK. So I'll talk about that and whether our forecasts were correct. The third part of the talk, or the third study that I'll consider, follows on from the second. So, and we'll all be aware of this as well, because I think similar things have been introduced across the USA. But when the vaccine had started to roll out, there was talk about vaccine passports, and these are also known as vaccine certificates or proof of vaccine certificates. So an electronic or a hard copy of your proof of vaccination status. And what we wanted to do, again, before these were introduced, or there was talk of them being introduced, is to study whether their introduction themselves might change people's perceptions towards the COVID-19 vaccine and whether it might change their intention to vaccinate with it. So after I talk about those 3 studies, I'll talk about some of the current challenges that are going on at the moment in vaccine confidence. So I'll begin by just highlighting really or underlining the importance of vaccines. So this is a table that I've taken from a 2007 paper by Rausch. It shows the reduction in disease mortality and morbidity for a range of diseases from the pre-vaccine era to the post-vaccine era. So on the left, you can see a range of vaccine preventable diseases, the recorded number of cases and deaths in the pre-vaccine era, which was from the early 20th century up until about the 1960s, although the precise date will depend on the vaccine because they were introduced at different times. And you can see that for most of those diseases, there's been 100% reduction in deaths. So of note there, smallpox is the only disease that we've eradicated from the world. We've come very close to polio, although, as you might have noticed recently, there's been a lot of media, both in the UK and the US, that polio is sort of making a comeback, which is bad. And part of the reason is because of lower immunization rates over the past few years because of the COVID-19 pandemic. And I'll talk about that as well. So as I said, there's been substantial progress towards increasing vaccination rates and decreasing mortality and morbidity burdens. So in 2019, before the COVID-19 pandemic, the WHO, the World Health Organization, estimated that vaccines prevent about 4 to 5 million deaths per year. And now that doesn't include the lives saved due to the COVID-19 vaccines. And they're estimated, a recent paper in The Lancet estimates that they've probably saved about 14 million lives worldwide. And that's in the first year of rollout alone. And it's claimed by many that vaccines are the medical intervention with the greatest beneficial impact on human health and longevity. But nonetheless, there are still current challenges. Despite all the progress that we've made, there are still challenges. So the WHO estimate that if we were to improve vaccine uptake across the world, we could save an additional 1.5 million deaths per year. And because of some of the confidence losses that have caused people to not take vaccines, in 2019, again before the pandemic, the WHO listed vaccine hesitancy as a top 10 threat to global health, along with things like climate change. I think the biggest challenge at the moment, and again, I'll talk about this later, is that in July 2022, so a few months ago, the WHO released their annual estimates of national immunization coverage. So every country reports to the WHO across a range of vaccines and says what their immunization rates are. And at the moment, we've had the biggest fall in 3 decades induced by the COVID-19 pandemic. So what are the barriers to vaccinating? Now, I think a lot of people might disagree on this, but I think it's conceptually it's easier if you think about 2 main types of barrier. So you can have supply side barriers, and these are if you want to get a vaccine, but there was something physical stopping you, and demand side barriers. So if vaccines are readily available to you, but you have some kind of belief or attitude, something is preventing you from getting a vaccine. So the supply side barriers can include things like access to vaccination clinics or access to vaccination services. Is the vaccine actually available when you go to seek it out? Is the vaccine affordable to you? So not all vaccines are free, and this varies from country to country and healthcare system to healthcare system. There might also be language and information barriers. So public health services might not be communicating in a way that is understood by people in certain communities, and that might then prevent them from knowing how to get vaccines. But the focus of today's talk, I will focus more on the demand side barriers, and in particular vaccine confidence. So the demand side barriers might be your perceived risk of disease. It might be the confidence, your confidence in systems that deliver vaccines. So have you had bad experiences before? Or do you distrust people that are recommending vaccines? Do you distrust the government, for example? What we do at the Vaccine Confidence Project, at least in our big global surveys, is we ask about confidence in the vaccines. So we normally have 3 questions that are included in our surveys. Do you think the vaccines are important? And that also relates to disease risk. Do you think that vaccines are safe? And do you think that vaccines are effective? We've been moving, we have our 3 standard questions, and we also ask them about specific vaccines. And more of our recent work has looked at whether people view specific vaccines to be important, safe, and effective. And I've just popped a recent review here of a lot of the recent measures of vaccine confidence. People go about this in different ways, and so if you're interested, I would yeah, recommend you read that review article. I don't think there's a need to note it down. I think my slides will be shared later. So what happens in a vaccine confidence crisis? So I'm going to talk through 2 examples to really illustrate how bad things can be. So in Philippines, a vaccine was introduced against the dengue virus, but the program was stopped in 2017, which is the black vertical line on the Philippines graph on the left-hand side, when the drug manufacturer advised the government that the vaccine could put previously uninfected people with dengue at somewhat higher risk of a severe case of dengue fever. What happened then was a political controversy that erupted across the country, and people were trying to assign blame to different factions within the government. But the fallout from this was that parents with a recent child that had died blamed the vaccine rather than dengue, for example. So what I show on these 2 graphs, actually, but it's the same for both of them, is 3 routine immunization vaccines, not the dengue vaccine, 3 routine immunization vaccines available to children. So the pink line is diphtheria, tetanus, pertussis containing vaccine. Green is a measles containing vaccine, for example, MMR, and the blue line is polio. And what you can see this, well, a substantial decrease in immunization rates across Philippines, across vaccines that are not related to the dengue vaccine. So this is a very clear example of where a confidence loss in one vaccine can trigger confidence losses in other vaccines. And the result of these declining rates were huge outbreaks of vaccine preventable diseases across the Philippines. In the United Kingdom, we have recently had, well, recently, 1998, there was a paper that has since been withdrawn for being fraudulent, essentially, that was published in The Lancet by Andrew Wakefield. And in that paper, he had claimed a link between the triple dose measles vaccine, MMR, and autism. And again, what followed here wasn't so much a massive political controversy, but there was certainly a media storm that erupted. And as you can see from the green line, which is the measles containing vaccine, so MMR, we had a 10% fall, or 10 percentage point fall in our measles immunization uptake rate, measles mumps rubella immunization rate. And it only recovered in 2012, so over 10 years after the scandal, and now unfortunately seems to be decreasing. What happened here, though, was very vaccine specific. It turned out that this confidence loss in one vaccine didn't really affect confidence in other vaccines. But it gives you an idea that a confidence loss in one vaccine can trigger confidence losses in others. So hopefully I've convinced you why we need high coverage. But one thing that's often not spoken about enough, I think, is that we need high coverage everywhere, i.e. we need high coverage locally across the country. So to explain why local vaccination targets matter, I'll quickly touch on the concept of herd immunity, although I'm pretty sure you're well versed with this after the past 2 years. So herd immunity is basically the concept that if we can get a sufficient number of people immunized in a population, then epidemics won't occur, which is what the graphic on the right shows, that these red infected people they're not connected to enough blue people, healthy individuals, to spread the disease. So the disease will eventually die out. Now, there are theoretical values for the vaccination coverage required to obtain herd immunity. And so for the measles virus, you might have heard a 95% vaccination target. But actually, when calculating that figure of 95%, it's assumed that individuals are sort of randomly distributed in the population, i.e. not what you see on the right graph here, where you've got this sort of blue cluster in the middle, but individuals are randomly distributed. What 2 authors showed in 2008, Salathe and Bonhoeffer, is that if you don't have this random distribution of unimmunized in a population, i.e. if they cluster geographically, then what happens is you have an increase in outbreak probability. So what this figure shows is on the x-axis, you have the amount of clustering of unimmunized people in a population, ranging from 0, which is what I was just talking about, completely homogeneous or random spread of unimmunized people in the population, to 1, which is that you have these very local pockets of clusters of non-immunized people. And when that happens, there is an increase in the outbreak probability, i.e. you don't have herd immunity anymore. Epidemics will form. And so that's That's important when thinking about vaccine confidence. And one of the things we've been doing at the Vaccine Confidence recently is moving from our national surveys to try to understand local levels of vaccine confidence. So what do we do at the Vaccine Confidence Project? Well, I think our director, Heidi Larson, sums this up quite well. The overall aim is to keep our finger on the pulse of vaccine confidence, and we have a number of tools that allow us to do this. We have social media surveillance, where we try to monitor social media forums, and we try to understand what concerns are forming online. We have focus groups and in-depth interviews where we might go into a certain subpopulation and try to understand specific barriers. But what I'll talk about today is our national and subnational survey work. And typically what we've done here is we've collected a large number of surveys since 2015, national surveys of about 1,000 people. And these are nationally representative surveys as well. And as I've mentioned before, we asked them 3 questions, sometimes 4, but I'll focus on 3 today, whether people think that vaccines are important, safe, and effective. So when we do these nationally representative surveys, they're representative by age, sex, and subnational region. So for example, if we were surveying the United States, we would survey more people in Texas, Florida, New York, California than we would in other states because they have higher populations. We'd survey roughly 50% male and roughly 50% female, and the age demographics that we survey would match the national distribution. So what I'll do now is I'll talk about the first study that I mentioned, mapping global trends in vaccine confidence. So what we wanted to do here, our study goal was to harness all the data that we've collected so far at the Vaccine Confidence Project to build a global picture of the state of vaccine confidence and how it's evolved over time. The table here shows all of the survey data that we've been collecting since 2015. These are all different projects. We've done them for sort of different reasons, but the purpose of this project was to say, hey, look, we've got all of this data about vaccine confidence across the world, asking these 3 questions. Can we estimate the values or the percentage of people that agree with those 3 statements? Overall, I think vaccines are important. Overall, I think vaccines are safe. Overall, I think vaccines are effective. Estimate those values at each time point, even though we haven't surveyed each country in each time point. So it's sort of a data and modeling challenge. So there are 2 outcome variables in this study. The first is what I just mentioned, perceptions towards safety, importance, and effectiveness of vaccines. People will answer that on a 4-point Likert scale. So they can strongly agree with that statement. They can tend to agree with the statement. They can tend to disagree or strongly disagree. We have a second outcome variable in the study because in the Wellcome Global Monitor, which is the 4th row of that table, a question was included in that survey to measure people's coverage. So the question was asked, have any of your children ever received a vaccine to prevent them against a childhood disease? And what we wanted to do as well as part of this study was to understand the determinants of vaccine coverage, as well as mapping vaccine confidence over time. So I said I wouldn't get into too much of the maths detail, and I promise I won't, but we used a method called Gaussian process regression modeling. I've actually forgotten to put the reference here to the paper. But essentially, this is quite a neat modeling tool because even though we don't survey every country in every year, this method will allow us to estimate a percentage of people agreeing with a statement in the year where we didn't have a survey, based on previous data that we have in that country, and also based on what the regional trends are. So for example, if we're estimating vaccine confidence in the UK in the year without a survey, an estimate will be based on the previous year's data, as well as broad European trends. And as I said, we also want to look at the determinants of vaccine coverage in this paper as well, with that one question that was included in one of the surveys. So these are what the results look like. I hope you can see them on the screen. I'm sort of doubting this now. Maybe I should have done 1 map per screen, but I'll point out some broad trends anyway. So what this figure shows is the percentage of people who strongly agree that vaccines are safe. That's on the top row. And the percentage of respondents who strongly agree that vaccines are important. That's on the bottom row. On the left column, you have November 2015, and on the right column, you have November 2018. So some broad trends emerge here. You should be able to spot that Europe and Central Asia is looking quite bad. So the orangey colours are lower lower percentage of people who strongly agree with those statements, and bluer colours are higher percentages. So Europe is quite low in confidence, similarly with Central Asia, similarly with Japan. Another trend that strikes you quite immediately is that a higher percentage of people strongly agree that vaccines are important compared to vaccines are safe. So people tend to view vaccines as important but have safety concerns with them. This study also picked out the decreasing trends in the Philippines and specific examples of low confidence. Japan is quite red, and Japan has had a lot of distrust with the HPV vaccine previously, largely driven by anti-vaccination movements. Surprisingly, the Japanese Ministry of Health actually suspended that vaccine in 2013, which surprised a lot of public health policymakers. They've since reversed their decision, but that might be one of the factors why vaccine confidence is low in Japan. Similarly with France, is quite a dark red. I think France might have been the lowest confidence country in the world here. And they similarly have issues with the HPV vaccine. So in this figure, I'm showing the determinants of coverage. So the determinants of whether a child has ever received a vaccine. So I'll just take a moment to explain the graph on the right-hand side. Each dot denotes a country. If the dot is to the right of the vertical dotted line in the middle, it means that the variable on the left is more positively associated with vaccine coverage. So for example, if we take the first three rows, vaccines are effective, vaccines are safe, vaccines are important. We use those three vaccine confidence questions as a predictor of vaccine coverage. And unsurprisingly, if you're more likely to report that vaccines are effective or safe or important, you're more likely to report your child having ever had a vaccine. Similarly, for education, if you have a high science education or if you have a high general education, you're more likely to report your child ever having had a vaccine. Similarly, for income, higher income groups report the same. Interestingly, if you report being of a minority religious affiliation, you are less likely to report coverage for your child, uptake for your child. Trust sources varied a bit here. In fact, if you notice governments, all of these effects are in one direction. If you have high confidence, you have high coverage. If you have high education, high coverage. We found it interesting that we sort of had almost like a polarized or a bipolar effect with government, where either very high trusting government or low trusting government could be predictive of high coverage. And one example, one of the countries below or to the left of the line here was the USA, where so recent studies have shown that Democrat voters tend to have higher confidence in vaccines, more likely to report that their child would have had at least one vaccine. But they, at the period of this study, which was in the Trump administration, they did not trust the government, and so that was one country with a sort of that negative association. In terms of sources of trust, if you do not trust doctors or nurses the most, if you trust other sources or people in your social circle, you're much less likely to report vaccination coverage for your child. And the last finding is if you're high in information, if you're high in healthcare information seeking behaviour, you're also likely to report that your child has had at least one vaccine. So now I'll move on to the second study that I introduced previously, and this is a COVID relevant study. Our study goal was to predict uptake of a COVID-19 vaccine before the vaccine was rolled out in the UK. Now, this study was initially performed with the idea of identifying those local clusters of unimmunized people that I spoke to you previously. I think since then, though, and even early in 2021, it became apparent that these vaccines weren't sterilizing, that you could still be vaccinated and get infected. And so the initial purpose of this study had kind of, it was, I guess it was no longer valid in a way. But one aspect of this study where it was extremely valid is that we could give policymakers in the UK, in particular NSH England and NHS Communications, robust local level estimates of the number of people that would take a vaccine when it was made available to them. So the map on the right shows at least most of the United Kingdom. Scotland's been a bit cut off as has Northern Ireland. And the table shows the number of people that we surveyed across each broad region. Now, we do go into 174 regions. This is just giving you a summary across each broad region of the UK. I noticed earlier that I said that we've surveyed about 1,000 people per country in our national level surveys. But here we survey more than 1,000 people in each subnational region of the UK. So it's a really high-powered survey. So there was only one outcome of interest in this study. The question that we asked people was, if a new coronavirus vaccine became available, would you accept the vaccine for yourself? And there were 4 possible answers. People could say, yes, I definitely would take the vaccine. I'm unsure, but I'm leaning towards yes. I'm unsure, but leaning towards no, or no, definitely not. We also collected a number of explanatory variables as well. We collected people's outer postcode. That's a geographic unit. It's much like the zip code in the US. And that allows us to basically provide these subnational estimates. We collected people's sex, age, religious affiliation, highest level of educational achievement, etc. The reason why we collected these socio-demographic data is twofold, really. The first is because we're interested in understanding the relationship between these factors and whether people would get a COVID-19 vaccine, because that can impact policy. But from a practical perspective, and the modelling that we use for this, these variables align with census data that was collected in the UK. And we have millions of census records in the UK. And the idea was to match the number of people that we surveyed in the sample with the number of people in the census for each local region in the UK and provide a real robust reweighting. So again, this is another, I guess, a technical slide. I won't go into too much technical detail. I've given a couple of references below, which I would encourage you to follow. So if you're interested in this method, go to the first reference. And if you're interested in the first part of this method, multi-level regression, then the textbook at the bottom is very good. So we use a method called multi-level regression and post-stratification. It sounds quite complicated. It's not. I'll explain it. And it's sometimes known as Mr. P or MRP. So this is just a 2-step procedure. The first part of the model is multi-level regression. This is just like a regular regression. You want to explain the relationship between a response variable, in this case, intent to accept a COVID-19 vaccine, and covariate data, which I showed you on the previous slide. But here, the data contains a natural hierarchy or a multi-level structure. So here, the individuals are nested within these 174 regions of the UK. The benefit of this model is that it allows information to be pulled or borrowed from neighbouring areas, if you like. So let's suppose of these 174 regions, and we've got 17,000 data points, we expect roughly 100 data points per region. But let's suppose that in one region, I've only got 10 people surveyed. Well, that's not going to give me a reliable estimate. Through random means, we don't know much about the certainty of this estimate, and error bars would be quite large. What multi-level regression does is allows the estimate in this small region, or a region with a small n, to be pulled. It borrows information from the rest of the country and sort of projects onto that region. And in this way, this method has been shown to be robust. It gives you reliable predictions if you use this. So the second part of this method is post-stratification. So once you know the probability that a given person of a given socio-demographic background will take a vaccine in a given region, you can reweight with all the census data that I said before. So it's post-stratification is just a weighting process where survey respondents are weighted according to the number of times that person with their specific socio-demographic information appears in the population. And here are the results. So what these two maps show, on the left, you have the percentage of people who said they would definitely take a vaccine across 174 regions of the UK, and on the right, the percentage of people who said no, definitely not. I've left out the unsures. So this modelling study was done in October 2020. The first vaccine was administered, I think, in late December of the same year in the UK. And we found that across the country, so not looking at subnational trends now, but overall across the UK, about 48% of people said they would definitely take the vaccine. About 33% were unsure but leaning towards yes. So that's only 80% of people. And in fact, as I'll show in the next slide, the current immunisation rate for at least one dose of COVID vaccine among adults in the UK, which was the cohort here, is about 90+%. So clearly, as the vaccination campaign went on, people became more confident. About 20% of people overall said either I'm unsure but leaning towards no, or no, definitely not. Now, if we look at the spatial variability in the UK, now I don't assume that you'll know a lot about UK geography, but I've flagged out London here, which is, I don't think I have a mouse to point, but you can see it, it's sort of, yeah, to the south and to the east a little bit. That has the lowest level of vaccine confidence, or at least the lowest intentions to take a COVID vaccine in the UK. The other dark blue regions on the left, or light orange regions on the right, are all large urban areas. So Manchester, Liverpool, Birmingham, all were predicted to have quite low vaccination coverage rates for the COVID-19 vaccine. So how well did these forecasts do? Oh, that's reference to the paper. How well did these forecasts do? Well, I think we did pretty well here, actually. So what I did recently was I got all of the vaccine coverage data, the first dose vaccine coverage data from September 2021. And what I do on this graph is on the x-axis, it's got the predicted uptake, and on the y-axis, you've got the observed uptake. And September 2021 is when all adults had been offered a vaccine in the UK, COVID vaccine in the UK, plus 2 months. So this should be quite reliable data to compare it against. We find a correlation coefficient of 0.7, which is quite good. It's significant. One interesting thing from this graph, though, again, I don't know how well you're seeing the colors on the screen, but if you look at the left-hand side, or the lower left-hand part of the graph, so that's, if you look at, low predicted values, they're actually below the y equals x line. So these are doing worse off than they should have done. And similarly, on the right-hand side, a lot of regions are doing better off. Now, what's interesting about the regions that are doing worse off than their prediction is that they're almost all from London or big urban areas in the UK. So there's something happening there. Something has happened over the past year. Maybe the messages from the NHS have broke through with people in non-urban settings, but they haven't quite got through as well as we would have liked in large urban areas in the UK. Now, one reason for that is just the socio-demographic types, if you like, the characteristics of these regions. So what we found, so this figure here shows the extent to which each of these covariates predicts COVID-19 vaccine acceptance. So again, we've got a vertical line in the middle. If the point is to the right of that line, it means that that parameter, which is shown in a sort of a second column from the left, it means that that parameter is more likely to take the vaccine, or to report that they would take the vaccine, than the baseline group. The baseline group is shown in brackets in the sort of blue-purple column on the left. So if we go down this plot, we can see that initially males were more likely than females in the UK to say that they would take a COVID-19 vaccine. Actually, that trend has reversed slightly now. So what has happened over the course of the COVID-19 vaccine rollout in the UK is that females have become more confident in the vaccine. And one reason for that is that there was some trepidation early on that there might be negative side effects that impacted pregnancy, and those fears are now at 8. And I think the NHS has done a tremendous job in the UK to get women vaccinated. We can see if we go down again, we've got age. And as you increase age, you'll become more likely to report willingness to take a vaccine, which makes sense because older people are more at risk from COVID-19. Again, we see this effect with education. So level 4 is a high level of education. The baseline is level 1 to 3. So if you have the highest level of education, which would be university or greater in the UK, you're more likely to be vaccinated. And then with religious affiliation, Muslim groups, and if you refuse to provide your religion on the survey, then you're less likely to report willingness to take a vaccine. Black and Black British ethnicities in the UK are less likely to take the vaccine, and non-English speakers as well. And this explains a lot of the reason why we saw these low willingness to accept the vaccine in urban areas in the UK. These populations tend to be more ethnically diverse and younger than other parts of the UK. Okay, so I'll talk about the final study now, the final of 3. So after the vaccine was rolled out, there was a lot of talk in the UK about whether we should introduce vaccine passports. The main reason cited for introducing vaccine passports was to provide safety and security inside certain venues. So what the venues that were proposed were sports event theatres, pubs and restaurants. So what we decided to do was to, again, do another large-scale survey in the UK. So this was conducted in spring 2021. We surveyed another 17,000 people in the UK, and our goal was to assess the impact of vaccine passports, or the possible impact of vaccine passports, on people's inclination to receive a COVID-19 vaccine. So I said we surveyed 17,000 people, but once you remove from that sample anyone who'd received 2 doses, you're left with 13,416 people. The reason why we removed people who had had 2 doses is because we wanted to explore future vaccination intent. And at that time, no one was talking about booster vaccines, or at least we weren't aware of it. So, so we wanted to probe attitudes among people who still had another vaccination opportunity left, either 0 doses to 1 or 1 dose to 2. Now, there are 2 questions we wanted to ask here in order for enable us to do this modelling exercise. The first was intent on receiving another dose, and the possible answers were the same as in the previous slide. The second, which was asked after this first one, was if the coronavirus or COVID-19 certificate or passport, and we defined what that was before we asked this question, if it was required to attend social events in the UK, such as sports events, theatres, pubs, restaurants, would you be more or less inclined to accept a coronavirus vaccine? And there were 5 possible answers, ranging from more inclined to less inclined. So the aim of this, again, this is another modelling study, but we wanted to estimate this joint probability, the probability of Y and Z. So for each pair of responses, we want to estimate how many people fell into each pair of responses. And then what we'll do is we'll sum everything up and have a summary statistic at the end. Now, I'll describe this summary statistic quickly, and it's our motivation for it. But effectively, when we want to sum up the responses in this table, what we want to do is people who say that they would, yes, definitely take a vaccine, and vaccine passports make them much less inclined or somewhat less inclined, well, that's going to count negatively towards this sum. That's going to be a bad thing. Similarly, unsure lean yes or unsure lean no, if you become much less inclined or somewhat less inclined, that's also going to drive you down. That's a negative thing. Conversely, if you're unsure lean yes, unsure lean no, or no, definitely not, but you say you're more inclined, well, that's going to count positively towards this sum. And everything else we don't want to include, because if you say yes, definitely, you're already going to take the vaccine. So it doesn't matter whether you're going to become more inclined or much more inclined. And there is some survey evidence that suggests that when you ask these types of questions, you're just kind of, your view in the first place is going to correlate with your change in perception. So what did we find? Well, these are the raw values. So this is the percentage of people that replied to each pair of responses in a population. But these are the ones that we're interested in, because we don't want to include the grey ones that I showed before. And the total change in inclination turned out to be minus 3.7%. What this means is that people who are somewhat reluctant to vaccinate are becoming less inclined to vaccinate if passports were introduced. Now, there is a caveat here in that this might not necessarily well reflect real world intentions. You might say it because it's a survey, and you might not go on to do it. Interestingly, though, vaccine passports did get introduced into the UK, and we didn't see a marked shift in vaccine uptake, like we did in France, for example. So this isn't the only study that's looked at this. There have been some other studies which I cite below. So Porat et al. Look at this in the UK as well. In fact, we were both working on this at the same time, but didn't realise that we were. We both came to a very similar conclusion. In the US, this Isham-Wilson paper, I think she's at the University of Washington, but they find a similar thing for the US as well, that vaccine passports or vaccine certificates might bolster confidence in the most high confident groups, high vaccine confidence groups, but they might build distrust within groups who are a little hesitant. So I think I think there's certainly evidence there that suggests they might not be a great one-size-fits-all tool. Okay, so what are the wrap up now? What are the current challenges? Well, I've pulled this fact sheet, if you like, from the World Health Organization website, because I think it really drives home what the major challenges are at the moment. So global vaccine coverage has dropped from 86% 2019 to 81% in 2021. That's the biggest year-on-year fall in vaccination coverage in 3 decades. And that has largely been induced by the COVID-19 pandemic, where resources are often already stretched and some of them are being diverted to the COVID-19 vaccine rollout rather than existing immunization programs. Currently, there are 25 million children under the age of 1 that didn't receive basic vaccines. That's the highest number since 2009. So the COVID-19 pandemic has really disrupted progress towards vaccination coverage, vaccination uptake. And what I'd like to leave you with is the following. When these statistics are used, and I've seen them used a lot in recent publications and press releases, all of the focus is on supply side barriers rather than demand side barriers. So it's kind of blamed on the COVID-19 pandemic and access to vaccines. But what I would like to perhaps suggest as well is that we need to keep a close eye on the vaccine confidence picture. So this is some data that is literally fresh out of the oven that I made a couple of days ago. So this is some recent surveying that we've done in the European Union. And what this graph shows is the percentage of people agreeing that vaccines are important and vaccines are safe, but broken down by age group. So you have 65 and over in green and 18 to 34 in pink. And what I think you can see, and I've made some summary statistics, although I haven't shown it here, is that there is an increasing age vaccine confidence gap between the youngest group and the oldest group. So in a lot of countries, over 65-year-olds have sort of become as secure or more secure about vaccines. And obviously, they're very high risk of the COVID-19 vaccine. But it seems like in a lot of countries, younger age groups are becoming less confident in vaccines. I do not know the answer for this, but if I could leave on one point, I would say that trying to understand this and trying to understand if COVID-19 pandemic has also impacted use towards routine immunizations, then that's something that we need to keep a close eye on. So thank you very much for your time. I'm more than happy to answer questions.
Okay, here's a question. My family's French. Most of them are unvaccinated and have paid to have fake vaccine passports. They got them from healthcare professionals. How does this affect things like disease tracing? Are fraudulent vaccine passports common in other countries in Europe or not? How much of this hesitancy is related to information shared by healthcare professionals?
Yeah, that's a very interesting question. Thank you for that. So I'm not sure how much I can answer that question, all the questions in it. So certainly vaccine passports are not uncommon. In the UK, they were being sold, I think, quite openly. And yes, I've read about stories of it happening across Europe more broadly as well. As part of this, the last slide that I showed you about the recent work that we're doing with the European Union, we surveyed 27,000 people across the European Union, about 1,000 in each member state, but we also survey 100 healthcare workers. And I'm literally working on that data now. So I can't tell you whether they're becoming more or less confident, but what we know is that in certain parts of Eastern Europe, vaccine confidence among both the general public and healthcare workers is quite low, including healthcare workers that recommend vaccines. So it would not surprise me if there were some parts in Europe where healthcare workers were facilitating that.
So do you find that vaccine confidence is higher in males or females now, globally?
Yeah, I think it's hard to say as a global picture. It can often vary from country to country. It will vary depending on vaccine to vaccine as well. With regards to the HPV vaccine, in France and Japan, that's certainly higher hesitancy among females compared to males. But I think the picture is mixed and depends on a lot of factors.
So this person was interested in the lack of vaccine confidence in London, and they said, where did it go? Is there lower socioeconomic status in the larger cities?
Yeah, so that's certainly true in the UK. So large urban areas in the UK will tend to have younger populations. There'll be more economic inequalities. Yeah, and those are the factors that are related to vaccine passports. So when we wrote this vaccine passports paper, one thing that I was particularly concerned about was that, well, this effect that I just spoken about was that they were very good at people who were sort of pretty pro-vaccine and encouraged them to go out and get vaccinated. But in London, Manchester, Liverpool, Birmingham, which has quite high proportions of ethnic minority populations who have historic distrust towards the government and wonder often whether the government is working in their interests, they often perceive this as some form of state control. There was a lot of talk about it morphing into a digital ID, which sat very uncomfortably with them. So our concern was that this could backfire in London, and I would probably go so far as to propose that the figure that I showed you earlier with, can I bring it up? With the forecasts, I would suggest that one reason perhaps why coverage hasn't improved as much in the urban areas is because of these policies.
Is there a chance, every time a question gets asked, it moves up to the front. Is there a chance that part of the reason for non-English speakers in the UK were less likely to get a vaccine was because of lack of information in a language they can understand?
Yeah, that is certainly a factor. And I know that the NHS work very hard now with local clinics to try to make sure that they understand local population needs, and the information is written on pamphlets and advertisements in all of the local languages. So that wouldn't be happening if that wasn't an issue. So yeah, with Polish speakers, it's kind of an odd one. The UK has a very high population of Polish immigrants, and Poland is one of the countries that we survey that tends to have quite low vaccine confidence. And I don't know what the specific reasons are, but I imagine that that's a factor.
Right. So for the reason on why the younger generation is less keen on vaccinations, is it because of availability or the social groups they could be in?
Yeah, that's a great question. I probably should have mentioned that earlier. So I would speculate that the main reason why vaccine confidence is lower in younger age groups is because of the perceived threat of many diseases. So if we go back to the global map, this would also be reflected in this global map. So countries with high numbers of vaccine preventable disease outbreaks tend to recognize the importance of vaccines. And I think the reason why a lot of the Western world has lower confidence is because we've done such a good job at removing those diseases from daily life that we just don't recognize the importance. And I think that's certainly true in the UK, where it was definitely true with the COVID-19 vaccine. In almost every country you survey around the world, older groups, if you're more at risk, if you perceive yourself to be more at risk, you're much more willing to take a vaccine. So I think the perceived risk of disease plays a major role there.
Right. And what about exposure to social media? Do you think that younger people are more exposed to social media and possible misinformation than older generations?
Yeah, so that's an interesting question, actually. So we have done a couple of studies. I chose not to talk about them today for time, but so we did a misinformation exposure study in the UK and US, and I don't think we found that younger or older groups were more susceptible or less susceptible than each other. But I think in the UK, when we looked at a misinformation susceptibility test, and this paper will be published soon, I can definitely send it if people are interested once it's published. That I think we found that younger people were more susceptible to misinformation around COVID. I'll have to get back to you on that. But it certainly plays a role. So in the misinformation study that we did in the UK and the US, exposing people to COVID-19 misinformation like really reduces their chance of getting a COVID-19 vaccine.
So someone wants to know why there's such big differences in confidence in different countries, and what the countries with high confidence do that maybe they're doing something right.
Yeah, I think if I knew that, I'd probably make quite a lot of money by recommending policies to governments. So in terms of why some countries have low confidence, you could pick a country and there'll probably be some kind of vaccine confidence story there. So the classic examples with, for example, polio, and one reason why polio hasn't been eradicated or locally eliminated in these countries is because of a distrust towards Western medicine. That was true in Nigeria, in Afghanistan and Pakistan. But then if you go to France, it's confidence concerns over the HPV vaccine. Same with Japan. If you go to the UK, it might be concerns over the MMR vaccine. So it's sort of very context specific. And yeah, it's hard to know what's done well. In the COVID-19 pandemic, 2 countries that did extremely well in getting the publics vaccinated and also maintaining a very high trust in the population were Denmark and Portugal. Now, interestingly, both of those countries introduced vaccine passports. So if we'd run our study in those countries, we probably wouldn't have found the same effect as the UK. But both of those governments made sure in their early communications about vaccine passports, they were going to be time limited. So they only ran for a very short period of time and then they were stopped. And I think that sort of two-way thing where you're trusting the government and it seems like the government is responding to you and doing things that they said they would do, just builds a sort of a high trust environment. So every year in our State of the European Union vaccine confidence, Portugal comes out as number one, and they tend to just have very high trust in their government.
Great. Let's see. Do you think if we repeated the confidence survey today, there'd be different results?
Yeah, again, a really, really good question. And in fact, we have collected data. So this map that I showed you sort of goes up to the end of 2019. And if it wasn't for COVID, there would be more data that was sort of added to this, but we are working on that at the moment. So throughout COVID, we've been collecting more data, and we always include these 3 questions just so that we can build up this picture. And yeah, that will be coming soon. Again, I can keep you updated on those findings. We haven't looked at the data yet, but we are literally about to.
Wonderful. Any last question, anyone? Okay, let's thank Dr. De Figueiredo.
Thank you.